we are going to start our sessions for today. The first speaker is very, very esteemed Dr. Martien Brands from Netherlands. Dr. Martien, he's a clinical researcher and he has been the medical director of Noord Holland, Amsterdam. Can we have Dr. Martien Brands on the screen, please? Yes. Welcome, Dr. Martien. Welcome. And if I had to list your achievements, we would have to go on and on. But just in brief, Dr. Martien Brands' main activity has been clinical knowledge and expertise. He has been working on education and research projects in different countries, such as Ghana, Bosnia, Kenya, and UK. He's a pioneer in the field of integrative medicine in Netherlands. Dr. Brands' initiative in providing a portfolio to the WHO on homeopathic treatment of major global endemics and epidemics through the malaria project in Kenya is a commendable step towards increasing public concern regarding antimicrobial resistance. Today, I would also like to share my own experience with Dr. Brands. Indeed, it was heartening and very, very inspiring to hear him at the World Homeopathy Day conference in New Delhi in 2019, where he presented a beautiful talk on how to address homeopathy in different settings, how to apply it in different settings through a module which he presented as a pyramid of health in public settings. And if we have the time and if it is possible, we would love him to share this today with all of us. And indeed, it is going to be very, very inspiring to listen to you, Dr. Brands. Welcome very much on this platform.
Thank you very much. I'm adjusting my own screen now. Just a moment. Yeah. Well, first of all, Dr. Naik, I thank you very much for collecting us together, because especially in this very chaotic times, we see the need for collaboration between homeopathy all over the world. And I think together we are united and we are stronger. And we need that strength to put homeopathy forward as a major option in public health. It has been always very strong in individual case taking, but there are many situations where we should think of other approaches, which already have been indicated by the founder of homeopathy, Dr. Hahnemann, in his model of epidemic diseases. So I've tried in this lecture to combine the two approaches, as I did indeed last year in New Delhi also, and which I have done the last couple of years on several occasions in Liga conferences, as I see a lot of internal discussions in homeopathy which turn into a stalemate. And this stalemate is because the individualization in homeopathy is, let's say, our golden standard. But in certain situations, we have to adopt our form of practice. And my suggestion today is that we also adopt our research methods on these different forms of care. So, second slide, please. Yes. Do you see the whole slide? I see that you do not see the whole slide. Yeah, maybe better put it this way, then we can go through them better. Thank you. As I said, the stumbling block for progress in homeopathic research is that we have different definitions of what homeopathy is and what it is not. And the practices vary, and how can we bring unity in this diversity has been my question since many years. And is there a common denominator in practice that we can use in our research typecasting? That means using different actors for different roles in a play. And for me, unity does not mean a dogmatic one-size-fits-all protocoling, which we reject in orthodox medicine because we think it doesn't suit the person. So I think we should have the same flexibility of mind when it comes to designing research protocols. So I propose to create a toolbox from where we can choose the most appropriate design in the respective situations. Next slide, please. As I said, the first step in homeopathy has been to deal with epidemics, because Dr. Hahnemann was faced with epidemics of yellow fever and cholera, and he found that a limited number of remedies was suitable for that disease. And this has been confirmed in many randomized clinical trials in the course of the years, even where individual prescription was used, that there were usually 6 to 8 remedies which covered, let's say, 85% of the cases. And what is the common denominator here is that we have symptoms on all levels, in epidemics also, but they are dominating the features of the persons which they have also when they are not ill. Next slide, please. In the course of time in homeopathy, a more comprehensive materia medica available, and especially chronic diseases start to be treated more, and certain remedies were linked to types of diseases. And this lent itself for the treatment of endemic diseases, which we also see now, like allergies, locomotor disorders, gastrointestinal disorders, skin disorders. And they need to be treated by physicians with a longer experience. And we see, for example, in many studies in France and Germany, and now also in India, that non-selected groups of patients who appear spontaneously, so they are not recruited like in an RCT. These patients, they appear in practice and they are being treated and being followed by cohort studies, and these cohort studies show a clear advantage of homeopathy over many conventional treatments. That's not to say that we should neglect conventional treatment, it's only to say that homeopathy certainly has a place in primary care. Next slide, please. And the third step has been the last step of the pyramid, so to say. Last year, I drew a pyramid of these 3 steps. Has to be the psychobiographical aspect of the remedy. They were already there in the provings, but there was no scientific framework yet available. And in around 1900, psychology developed as a science, and this has influenced the development of homeopathy as well. And in the same time, James Tyler Kent started to thematize the remedy patterns, which have been furthered by Vitulkas in the 1980s, when there was a revival of homeopathy. So this has made homeopathy a truly holistic system of medicine with a parallel to psychoneuroimmunology. Next slide, please. So what is the common denominator in these 3 steps? That is an increasing complexity from step 1 to step 3. And increasing complexity means even more symptoms and features are included in the diagnostics. And that's also a change from only quantitative symptoms, which can be measured on ordinal scales, to qualitative features, which have to do often with generalities and mental symptoms. And these are nominal in nature. So you already can see here that we might need to have different measurement scales to follow them up in an effect study. Next slide, please. So what then is appropriate technology in design? That means that these 3 levels, they are being practiced globally in response to the local situations. And I have seen in over 30 years of personal experience that these differ very largely. And I was confirmed by this in the study which we made in Kenya, where we did 3 different studies, all of which was focused on malaria, and malaria both as an endemic and as an epidemic disease. And simply we could see that they had very, not to say excellent results with their treatment, but they did not follow the classical approach. They used complex remedies, they used different remedies at the same time, which fits the multipathology of many people. They both had malaria and zoonosis, and they had like salmonella and hookworm, amoebiasis. So they had to find in let's say 15 to 20 minutes the appropriate treatment, and apparently they were able to do so by a lot of creativity and applying the laws of homeopathy, but in a community health setting. And at the same time, I've also worked with a group of Sankaran to work on their conversation techniques, as I did previously my PhD on conversation analysis. And that was very interesting to see for me the different requirements on methodology which we have in these different settings. And there the complexity in the sensation method is very, very high. That means we include a lot of data which are retrieved from the patient in sometimes hour-long consultations, and we compose the appropriate remedy picture. Next slide, please. We have been attacked, as Dr. Sujata said, and we have responded to that external pressure to prove homeopathy. And we have followed the mainstream trend for group designs like in RCTs. But the positive results of several reviews have not satisfied many conventional doctors. Apparently, maybe this is not the best tool for doing this job. And the job may be diversified depending on the level we are studying, the level of care. Laboratory studies are actually the best tool to show how it works, which is a basic research question, and what it affects is a clinical question. And so we need to assess the real needs of testing to improve our work in harmony with the 3 steps. Next slide, please. So I propose in epidemics where community healthcare is the setting of treatment to consider the practice. And when you have an epidemic, the main symptoms are dominating the whole picture. So the groups of patients you want to include in the research are relatively homogeneous. I'm not saying they are identical, but they are relatively homogeneous. And from an epidemiological point of view, the disease has a high incidence and a high prevalence. So the design can be matched groups of verum and controlled conditions in limited samples. The data are usually disease-bound symptoms, and they can form primary outcomes, which can be measured on quantitative scales, like what we can do with ordinal data. And the features may have an additional weight. Features having to do with the mental symptoms and general symptoms. So the protocol can, in these situations, be randomized placebo-controlled trials, and they have been successful in certain conditions being treated in rural clinics and in urban clinics with a highly homogeneous group of people. For example, there have been many studies in flu and in flu prevention, which are relevant to the current coronavirus epidemic today. And I think we can distinguish certain disease entities which have been proven to be effective tested on this way. But it's important to see that there are also other situations. Next slide, please. Because in primary care, where the diversity of pathology is much larger, we can, for example, distinguish the top 10 pathologies and they are when they are different, it's mainly due to climate and microbiological contexts. And in more than 80% of the subjects, as I said about malaria, diarrhea is another example, there is a small set of preferential remedies, and they have their effect for specific organs. And this effect is recording in the proving, so it's our empirical basis. And problem-based questioning and diagnostics are within the reach of most primary care workers, as extensive use and studies in Brazil, India, and Europe have shown. And here we can use cohort studies as the most preferred design. Next slide, please. So we have a moderate heterogeneity in patient illnesses. We have a high prevalence, but a low incidence because it's not an epidemic. The design is comparison in treatment outcomes in larger groups, and treatment outcomes in primary care have to be known on longer term. So we cannot use randomized clinical trials, as too many confounders will pop up in the course of the study. We can use the data from individual prescriptions, for example, documented with MAC repertory, and both symptoms and features are included here. And the protocol can be either a pragmatic study, conventional versus homeopathic, or we can do cohort studies with a case control or a single arm. These studies are better to account for the heterogeneity. So can you please show the next slide? When we work in advanced and classical care, which is implicitly taught in homeopathic academies as the only way to do homeopathy, which I think is closing the door for our practitioners to primary care, because I've seen in Holland many general practitioners leaving our professional organization because they couldn't apply the techniques which we were taught in their own practice. Because the practice of specialists in homeopathy is quite different. These are people which are usually pre-selected in terms they have been seen by several other health practitioners. They are being referred, and they are highly heterogeneous in their appearance. Epidemiological, it's a complex disease which would have a relatively low prevalence compared to the top 10 pathologies which are mentioned in primary care. So the design should be an individual assessment of non-standard primary outcomes. And with that I mean including the features which are dominant in patterns. And the symptoms have additional value. As we know, we can choose between 10 people with migraine, and they might get each of them a different remedy because of the influence of the features. So there is a gradual shift from the importance from level 1 to 2 to 3, from symptoms to features. So therefore, I advocate the use of structured case analysis as protocol and best case series. And recently there have been published some models which can support in doing that. And the method which I advocate here is time series analysis, because that is specially made by disciplines like education, movement sciences, and others, where individual differences are crucial to assess the patients. It's beyond this seminar to go into detail that, but it would be useful maybe to distribute some data on that. And we need to do next to the protocol a pilot exploration to choose primary outcomes from a pilot study in order to feed the time series analysis and structured case analysis. Next slide, please. So I think when we use a context-valid approach, we have enough tools at hand. It's only a matter of choosing let's say it is a more political decision to choose for appropriate design, as we are doing now in sustainability, also in homeopathic research. And because at the current situation, we often use RCTs where they are not the best option, and I hope to have shown it in this short presentation, and therefore we have a large chance of failures. And there are very many studies which have false negative results because the patients were not fit for the group designs. And let's use these trials which failed as wrecked ships as beacon on the beach, which is certainly a Dutch metaphor. So I advocate that we get a consensus of this type of contextual designing. Next slide, please. Yes. So the unity in diversity means here, let's reply to the research questions in the language of its formulation. So when the language is being spoken from a first, second, or third step on the pyramid, let's reply to that in the language itself. And I thank you very much for your attention, and I hope we can communicate about this further, because the honored founders of this panel have said this is a first step towards further research policy development. Thank you.
Thank you very much, Dr. Martien. It was a very, very deep, insightful, and yet such a precise explanation of the structure of the pyramid that you have been advocating for application of homeopathy in different settings. And in the light of this, there's one question that somebody has been asking. A couple of people have been putting this question. And considering that we are in the COVID times, this is but expected. So if you can just answer this in brief. The question goes like this: what will be the research protocol to establish the immunomodulatory effect of homeopathic medicine in treatment of COVID-19 patients or as prophylaxis? What type of immune marker will be investigated for that purpose? Would you like to answer that?
Yeah, I will try, because I'm not an immunologist, but with that restriction, there are certain markers which have been used in previous research, and I think especially of the group of Madeleine Bastide in France, where they have done many cytokines, interleukines, and used them as dependent variables. Well, we even talk about cytokine storm as a complication of COVID-19. So I think it's important, if we want to go beyond, let's say, the purely clinical evaluation, that we work together with immunologists. And I think there are now, because of the totally inappropriateness of many public health measures, there are many scientists who already thought out of the box, and they might also be interested to cooperate with homeopathy. They went out of the box because of the political implications in terms of limitation of civil rights in many countries, and we see now the disastrous effects on the economy and the health also of people. But I think, as I said, this crisis is also the opportunity to link up with people who previously were not involved in complementary research. And the exact immune modulator variables should be determined in some pilot studies. At the moment, I'm working only on evaluating clinical data, but let's say immunological data should form part of new studies. I agree with that. So let's try to link up with immunologists so they can advise us which are the best parameters to use.
Superb, superb. Thank you very much for answering that question. This was posed by one Dr. Milan Sengupta, who's a PhD in homeopathy. Dr. Sengupta, I hope you got an answer to your question, but you can again ask it to the other panelists also on board if you like. But meanwhile, thank you very much, Dr. Brands, and it was
You're
wonderful
welcome.
again to be
It
with you, and we hope to take this further. This
was
is
a
just
pleasure.
the thing on the cake. Thank you very much. And we go on to our next